Let's see. Hi everyone, and welcome to the last session of this first global conference in person-centered care. My name is Axel, and we just wait for some more to come. Perfect. Dropping. And as I said, warm welcome to our last, but not least, keynote session that we have during this conference. And it's really great that we're really honored to have two leaders in the field of patient advocacy and informal care that we will have as keynotes today. Anders Olausson, which is extensive experience in establishing and leading international patient organizations, and Dr. Elizabeth Hanson, an expert in informal care and policy development. And they will share their insights in the field of informal carers and the patient's pathway through the health, care and social services in both Sweden and internationally. And we plan to have both presentations in one session, and then we have time for discussion with both of them before we go over for the last section of the conference with awards and so on and so forth. So please, oh, Anders, you are behind me, okay. You can come from outside the garden, yeah? Good transition. So it's a great pleasure to having Anders here. And you are the honorary president of the European Patients Forums and also the chairman of the Ågrenska Foundation, Ågrenska Stiftelsen, a foundation for persons that have rare health conditions. And you have a lot others on your list, but I think that you are eager to start with your presentation.
I am.
So please, thank you.
Thank you. Thank you, Axel, and thank you very much for the kind invitation to be here. I must say that first, when I got the invitation to speak today to you all about the patient perspective in patient-centered care, I was very surprised. What can be said about this that hasn't been said before? Why do we need to talk about this still, and what is missing? My titles say something about this. The patient pathway necessitates a shift of paradigms. So let's look back a little. And in my life, the patient situation started some 40 years ago, even if it was much earlier for me as a person. I still remember when we started Ågrenska, and Åke Martinsson, who was the chairman of the collective patient organization in Gothenburg and had a son with a rare and unknown diagnosis who was very severe disabled. He said to me, Anders, in order to understand a parent to a disabled child, you have to be a parent to a disabled child yourself. And I thought that was stupid. Of course I can know. I can read, I can study, and I even thought that I was smart. Boy, wasn't I wrong. He was right, of course. So it takes one to understand one. Simple as that, already in 1990. In 1989, when we started, when we started the family program at Ågrenska, I used this picture to show that there are differences between royal people and ordinary people. The woman to the right, there you see, there's a queen, and she still looks like that. The guy next to her is me. 40 years ago. I shaved up since then. Anyhow, when we started the family program at Ågrenska, then we invited 10 families who had a child with the same diagnosis to come and stay for a week. We invited all the top guns in the various fields that their child was affected by: healthcare, social care, school, insurance, and adult life. All this knowledge was made into usefulness by the parents. because they together understood the true life of their child and therefore could make use of all the knowledge and even lift it up to a new level. So what Åke said earlier back then turned out to be correct. Or in the family's own word, let me show you what they said. I hate this clicking. I knew how to get it on the PowerPoint, but never to take it away. Okay, they said, 1990 they said this, and 2020 they say the same. Too few professionals had knowledge of rare diseases and the impact on individual and family. Efforts incomplete or wrong. Long time before diagnosis set needless suffering. Guided to the wrong parts of the system. Society efforts are not coordinated. System competence is lacking in many of society. Must be a carrier of knowledge. The family, I mean, the parent. Must always explain and defend their difficulties, disability due to the rarity and ambient ignorance. This is what the parent told me the worst part, especially for mothers. Because, you know, the number one job for a parent is to tell the world that my child is the best, beautiful, smartest, to bring the world to a new level. That's my job as a parent. When I come to the system doesn't want to know that. The system only wants to know what's lacking, what he can't do. And that hurts and pain. Need different stages to gain knowledge and meet others in the same situation. This new program was new at the time, and since then it has evolved even more. In the beginning of the 90s, the patient movement was really strong and growing. I remember when Eurodis was inaugurated, European Organization for Rare Diseases, and Organska became members, and I ended up in the board and soon became the president in 1999 and 2000. The institutions understood the importance of patient involvement, so strong at the time, so when the European Medicine Agency started the COMP, Committee for Orphan and Medicine Product for Orphan Drug, you know, in 2000, they let 3 seats to be appointed from the patient group. Eurodis got 2. In 2003, the European Commission understood this too, to the level that they invited all the European umbrella organizations to create the umbrellas of the umbrella. They started the European Patient Forum. And I ended up representing Eurodis and became president in 2005 to 16, and today I'm the honorary president. What I try to say isn't about me as a person, but rather that we, the world, the politicians, the doctors, the regulators, the researchers, we all have understood that nothing about us without us. I can go on and on to tell you everything that has been done around understanding the true value of patients' involvement to make all aspects of life better. To create, as the Italians say, a città di tutti. I love the phrase. So what is new then? Why do we still need to talk about patient perspective? Why hasn't all this knowledge been integrated in all legislation, rules, and handling treatment procedures, and so on? Let me give you another road mark of importance. We learned very quickly in the 90s that the world a person with a chronic diagnosis is depending on, healthcare, social care, school, insurance, and adult life, we always call them the big 5, have to work together, even act as one system. Because a person with a chronic diagnosis is depending on them, and his or her life journey goes across the silos. This is how the world looked like for the families, the silos. And look carefully how to see walls doesn't exist if your child is healthy. We have said this to the minister, we have said this to the government, we have said this to the legislators, and we have said this to everyone that want or wasn't and didn't want to listen. They even put it in the procedures of the healthcare call, both at European Commission and national, in the rules for healthcare to interact with social care and so on. But does it work? No, I'm sorry to say it doesn't. Sometimes it does, but that is not because of a good system, but rather good person within the system, but that is not sustainable. But in 2019 in Osaka, in Japan, a group of most important countries in the world, the G20, met and something big started. They met every year, and that year they met in Osaka, Japan. At the meeting, the Minister of Finance and the Ministers of Healthcare, you can see them there, Finance and the Minister of Healthcare agreed upon two things. First, we now need to create cross-budgetary system that follows the patient journey. We now need to evaluate and develop cross-budgetary system that follow the patient life journey. Second, we need to look at healthcare not as a cost, but rather as an investment. In my word, this is hallelujah. This was and still is a fantastic news. They finally got it and understood what is needed. It's about the money, and a new toolbox which changes from cost to investment, changes everything. Since then, the G20 and the United Nations have worked along this line, learning and trying to understand how to make the change so that the patient journey is passing the big five in a seamless manner. Let me look at this topic from another perspective. I talked to Ulf the other day, I don't know if he's in the room, and was very angry at him and complained about that they need a system that works like this, a seamless system following the true patient need. You remember, Ulf, that you got very angry at me and said, "This already exists, Anders. Didn't you know?" Yes, I did. I know what is written in the regulation and procedures document, but it still doesn't make the necessary change. Why? The times when it gets good, it's because there are so many good persons within the system of the big five, which all make individual patient life journey a good journey. But it's not sustainable. So we now can say that we can agree upon the following. I'll click again. I thought I was smart when I made the PowerPoint presentation. Okay, we agree upon this. We now know how the life journey looks like for various diagnoses. We have written in the system that the system need to cooperate. People within the system generally know this and agree upon its importance. We even started training in schools to call patient academy for learning so that patient can participate into drug development research. We call it European Patient Academy. We have even got a UN resolution about the rare diseases and accepted a General Assembly in New York in 2021. We have scientific results showing the importance of patient view is taken into account in all aspects of the patient journey, like that have been done at the GCPCC. We organize conferences like this one over and over again, saying all this and confirming with the knowledge that the basic line is still true. It takes one to know one. This is, I must say, very, very big. At the General Assembly in New York, at the UN. I love UN because UN is for me connecting the world. They accepted this resolution and showing in a holistic way you have to act. So how to make all this holistically and sustainable, like what I said at the UN Agenda 2030 with all the 17 Sustainable Development Goals. Yes, we have to involve many more goals than the third one of health. I love that, UN, WHO, UNESCO. I met Mr. Navid Hanif in New York last year at Universal Health Coverage, event where I talked about the patient pathway from a global perspective, which shows the seriousness that United Nations takes in our mission. In a meeting with Mr. Hanif after the conference, I presented to him our project, the Gothenburg Initiative, which is a project to identify the interaction a patient meets when crossing all the silos on his or her life journey and to initiate intervention to solve this. He said, "Anders, this is great. We want to participate in this, but you have to frame it." And what he meant is that you have to involve the SDGs and the UN Agenda 2030. I know for some of you might think that it's boring, United Nations too far away, Agenda 2030, yeah, who cares? But if we want to make a change, this is what all the state leaders within the UN have signed up to. This is one and the only door to pass. For rare and chronic diseases, we need at least take into account the following goals: 1, 3, 4, 5, 8, 9, 10, and 17. Let me tell you why. Number 1, negative cycle of vulnerability and poverty due to exclusion from health and education system and labor market create poverty. Universal health coverage, more and better, appropriate diagnosis and lifelong care and social support from holistic view, good health. 50% of chronic diseases affect children who often face difficulties in their school due to the physical inaccessibility and lack of appropriate teaching methods. 5, gender equality, recognition and evaluation of unpaid care and housework that many parents and carers perform to persons with chronic disease. Elizabeth will tell you all about it. 8, persons with a chronic disease and dysfunction are often marginalized from the labor market due to lack of physical availability, flexible working hours, and custom rules. 9, need to invest in research and development of therapies, health technology, and diagnostic methods. Access to infrastructure is a key to being included in society. 10, marginalized and invisible people who are discriminated against in the areas health, work, and self-esteem over their everyday life. And finally, 17, community for persons with a chronic diagnosis are increasingly interconnected with the multitude of patient advocates, regulators, research, and industry networks. The Gothenburg Initiative at Queen Silvia Children's Hospital here in Gothenburg embraces these goals, and multi-stakeholder partnerships are guaranteed within the project as Big Five. I think we need to add the following parts of the structure. We need to make, no, I didn't do the clicking. It's called developing. Politicians need to understand that the diagnosis doesn't go away if we don't carry through the changes. The healthcare professionals to understand that I as a patient hold a knowledge of my disease that is of high importance for my treatment, and it has to be taken into account to my treatment. The people that works at the Big Five understand that my own situation can only be treated in an optimal way by involving me and myself. If the above doesn't do this, we might need a system that corrects this, a system where all the silos in the Big Five works in a seamless way together. Because we have seen this in action when the outside actor like Agrenska Family Program intervene. Then the families handle the silos in a seamless manner. This pathway is very complex word to say, but what mustn't stop us from learning the complexity and fix it. I heard many say it's complex, and by that meaning it's not understandable. It is, and we have to do that. The procedure to speed up in order to implement what is the G20 said in Osaka 2019. It will be presented at the G7 meeting in Italy this autumn, and the goal is at the G20 meeting in New York 2026 to present this as a new way forward. Prevention, every hospital leader say. Prevention, prevention, prevention. If you listen to what the gurus say about tomorrow healthcare, they say the word prevention. What does that mean? No slide. You have to listen. Prevention means for me, what they say about prevention is that I as an individual person need to be more proactive to my own health. I as a person need to understand what is good and not good for me and act accordingly. We need to introduce supporting activities to make us all be more proactive in our own health. And I don't mean that I can fix my own chronic disease and make me healthy. I mean that I can make my everyday life better by acting proactive to what is best for me. And for that, we and I need to be supported by the big fives and the patient organizations, and speed up to implement what they already know into real actions. That is the consequences of prevention, what they are talking about. The future healthcare, to sum this up. The future healthcare, and remember when you heard this first, because I predict that in 10 years' time from now, in 2034, 50% of all healthcare that is done within the hospital or other healthcare facilities will be carried out in my home. That is in your home and in mine. Why? One of the biggest reasons is there is no money in the system, and will be no more money to it. And what are the consequences is that digital solution will march into our whole life, which is a fantastic possibility, I must agree. But what will happen to us who isn't familiar with the digital solutions, we who still live an analog life, and all other in our extended social life, helpers and others, Elizabeth, help us through there. We will hear more about that from you later. People will visit hospital less. This is good enough when you have a social situation where you have people around you at home. But what about us who doesn't have that kind of families? This will change everything, as we know, as ordinary healthcare, which leads to the need for a new and broader knowledge. The consequences of this major shift of healthcare has to be prepared. Otherwise, we as patients will suffer even more, which will lead to even higher cost for healthcare, since my chronic disease does not disappear if not being met by proper treatment. Real-life study data now. Showing what is right and working. Look what is being presented in this picture here. Just 2 days ago about cancer patient life. The tools are there. So we can't say we don't understand, we don't know how to understand what we don't understand. It's in there on the plate. So it's time to walk the walk. We need more data designed to help the last frontier to understand and adapt to their own world like we do in Upati. That's why center like GCPCC is important, but we need broader perspective, info and tools for the new toolbox for investment. You remember they are changing it from to look like a cost to investment. It's a major shift in toolbox and brings enormous possibilities. We can't accept that the system doesn't work according to the rules and knowledge we have set up. Then we have to act strongly to correct that. For instance, when the regulators look at how the healthcare and social care system that are set to work together in a seamless way for me as a patient, and it doesn't work as the rules say, and the result is poor, we have to put the foot down and say, no more, fix it. I saw an audit from a county in Sweden this winter that made an audit on how does this work. And it showed that 70% didn't work. And the reason was we hadn't had time to fill it in, we hadn't had time to follow it up, and we didn't have any money. And the recommendation from the audit, from the government was, oh, sorry, it's sad to hear, can you please be better? It's, however, a good sign that our Minister of Health, Mrs. Acko Ankarberg, have instructed her government to start a procedure to set up a national strategy for rare diseases in Sweden. Great expectation there. But for every day we delay this, the price goes up. And finally the price is too high, which I'm worried for. Which means that a less good alternative will be implemented. It is time to act now when we still can afford to and not afford to not to do. Yes. We got the knowledge, we got the scientific result that support this. We have a strong patient organization, we have the GCPCC, we have all of your result and research, academic knowledge, which is essential in this fight. So, what they sing in the gray shade of life, what are we waiting for? Thank you.
Thank you, Anders. Do you want to sit here or stairs? Outside. Thank you. So, thank you so much. And this brings us very nicely into our second keynote speaker of the day. So please, Professor Elizabeth Hanson. Here you are. Follow me all around.
Sorry.
Yes, yes. In the European Union, if you take 15% of all adults between 18 to 75 years, which are 52 million people, all of those are informal carers. And of those, 2/3 are women. And it's also, in that sense, it's very, very important to also discuss informal carers, which you also started with in the concept of person-centered care and person-centered health care systems. So I will stand here, I think, so I don't stand there. So you are a professor at the Linnaeus University here in Sweden. And you lead, I needed to translate it, I think, but you lead the informal carers care and caring research group at the university, which is the research arm of the Swedish National Competence Center for family care in Sweden, called NKA. And you have worked extensively with those questions.
Yes.
Yes, and that was a pleasure to having you here.
Thank you very much indeed, Axel, and for your kind introduction. I'd also like to thank very much Joachim Åhlén, Inga Ekman, and all conference committee members for inviting me to give you the final keynote this morning on such an important topic. It's a great privilege and pleasure to be here. As you're aware then, the focus of my presentation is on the role of informal family carers. I'd argue a key partner that sadly is all too often overlooked or taken for granted within person-centered care. I'd like to highlight for you that the framework for my presentation this morning is within a European context, mainly, but not exclusively. I've just realised I do need the clicker too, Anders. Here we go. Yeah. But first of all then, as a way of introduction, who are informal carers and how many are there? Within an EU context, as Axel has just highlighted, informal carers, also known as family carers, family caregivers, unpaid carers, are persons who are providing usually unpaid care, often on a regular basis, to someone with a chronic illness, disability, or other long-lasting health or care need outside of a professional or formal framework. And as you've already heard, they comprise between 10 to 20% of the total EU population, depending, of course, on how they are defined. And as you've already heard, it's estimated that just in the European Union alone, more than 52 million people, adults, 14.4% of the total EU population between the ages of 18 to 74 are providing care on a weekly basis. So I think it's true to say that caregiving will very likely affect nearly all of us in this room this morning, either as providers of care or as receivers of care. It's also very important to highlight that informal carers are indeed a heterogeneous group of people, predominantly in family members, but also importantly, wider relatives, friends, neighbours, work colleagues. Women provide at least 2/3 of all care, mainly as daughters or daughters-in-law. And equally importantly, the estimated economic value of informal care ranges between 320 and 368 billion euros per year, which I'm sure you'll agree far exceeds the budget devoted by our member states to formal long-term care. Very briefly then, in a nutshell, what do they do? Usually they're providing help with what we call instrumental activities of daily living, so help with shopping, cooking, collecting medicines, household tasks, to also providing personal activities of daily living, such as help with personal hygiene, help with toileting, moving and handling, to complex nursing care, such as wound care, monitoring symptoms, coordinating care, as you saw on the slide from Anders, and more. Some carers are providing lighter amounts of caring, between 1 to 9 hours a week, whilst others are carrying out 30 hours or more, and also a significant number are carrying out caring around the clock. What about then the impacts of caring? I think it's true to say that while some carers find it intrinsically satisfying and meaningful, others may find it highly stressful and burdensome. And I think it's true to say that for many, it may be a mixture of both. But generally speaking, we can see, as I've already said, that women actually to a greater extent experience than men, experience caring as physically and mentally demanding. And it's important to note that higher intensity caring over a prolonged period of time, and particularly when providing complex care, carries with it what we call a triple penalty. First and foremost, risks to their personal health, both physical and mental health and well-being, their financial situation, particularly for carers of working age, often having to reduce their number of paid working hours, or indeed leave the labour market altogether to provide care, which significantly affects their current income and their future pension. And thirdly, particularly for those high-intensity carers, it affects their social situation, leading in a number of cases to severe social isolation. Let's turn though now to the focus of this morning's presentation, which is in the context of person-centred care. I think we can see in many of the standard definitions of person-centred care, as you can see on our conference host website, that the informal carer, in this case the relatives, are visible within the partnership. But I think it's important that we're asking ourselves, though, to what extent are carers routinely identified, included, and more importantly, valued as partners within person-centred policy, research and practice. And that's what I will try and answer for you in my presentation this morning. So let us look at then the European policy context. I'd argue here in more recent years, significant progress has been made with regards to recognition of informal carers and their role within integrated person-centred care. Now you may be thinking, well, that's not surprising, Elizabeth, set against a context of population ageing, acute labour shortages, hot on the heels of the COVID-19 pandemic. But this first example is a major EU policy reform. It's the EU Care Strategy for Caregivers and Care Receivers, adopted by the European Council in December 22. It's the first strategy to focus on care. It clearly recognises the role played by informal carers. It calls on our member states to provide support, especially with regards to, firstly, gender dimensions of caring, and secondly, work-life balance. It also very importantly recognises that well-being is determined by the capacities of both professional and informal carers to provide good care. And it sees coordination between the two as central as they're working together with people with long-term care needs for a good situation for everyone, as we know from the GCPCC's concept from Recur of a good life with and for others. The second piece of important policy is what we call the Joint Partnership Agreement, signed in July last year between the European Commission and the WHO broader European region. The very first time WHO is focusing on long-term care. And they see this as, quote, vital for a better integration of health and long-term care systems. The focus primarily is on improving access and quality of long-term care services. But secondly, and I would argue equally importantly, providing important support to informal carers who they, quote, recognise as playing a crucial role in care provision. So I think you'll agree with me that they are two very important pieces of policy. Now, if we move to focus on research, my colleague, Elin Sofie Forsgärde, carried out a rapid review of the empirical literature from 2014 to April this year in 4 databases to explore person-centred care studies in the context of long-term care that in some way included informal or family carers. We identified 21 intervention studies, and I'd now like to present a modest smorgasbord of examples for you, just to try and highlight the state of the art. Well, I'm kicking off first of all and taking the liberty of starting with a Swedish intervention study that focuses on the potential of the carer support needs assessment tool originally developed by researchers in the UK. This is important because carers' assessment is a vital first step in order for the carers to ultimately access support that's based on their own needs and goals. It's a good example of how healthcare professionals, in this case nurses working in specialist home care, employ what we call a negotiated approach to carer assessment. The two are sitting down, discussing together the carer's situation, listening to their narrative, hearing what's important for the carer, together agreeing on an action plan that's then implemented and reviewed on a regular basis. I've just clicked up their details of the method. I'm going to be commenting on giving a comment about methodology at the end rather than after each example. Now, most of the examples or the studies we retrieved focused on carer education programs, and indeed one of carers' most frequent requests is for information, and yet more information. From existing research, we know that what we call multi-component interventions that at the same time are tailored to meet the individual needs of carers are more likely to be successful. So for my second example, I'm taking us to Singapore, where I'd like to highlight the Carer Matters programme. It's quite a comprehensive hospital-to-home programme targeted at carers of hospitalised older people. As I say, a multi-component programme, elements of tailoring, because it's based on a needs assessment so that enrolled carers, based on that assessment, access self-directed learning materials, in-person training courses, and it includes extra telesupport for those carers deemed to be at higher risk of burden. And very importantly, links to a community-based caregiver support network, which includes peer support, as you've already heard, the importance of from Anders, often highly valued by carers themselves to talk to others in a similar situation to their own. I'm now going to take us to Scotland, where this time we're going to have a broader focus on what I call the whole family, so a whole family approach, traditionally much more common within healthcare of children and within palliative care, for example. So the family group conference intervention includes, wherever feasible, the person living with dementia and their family, significant others, sitting down with coordinators who importantly are independent of any professionals involved with the family. So the person with dementia and family discuss their needs, what's important for them, identify resources, both within the family and with the help of the coordinator, also identifying external help and support, so that in this way they find and agree on potential solutions together. This leads to a family plan that's then implemented by the family and external agencies as appropriate, and then subsequently reviewed with the help of a link person identified and agreed on by the family. so that they review together and see what's worked and if they need to make any changes. And that's a little bit there about the methodology. Now, moving on to perhaps broader person-centred integrated care interventions, we actually found very few which involved directly the carer within the decision-making process, with a notable exception of a community programme intervention study from the Netherlands called the Care Chain for Elderly or Older Person. This involves a nurse practitioner carrying out a comprehensive, what they call geriatric assessment of the needs of the frail older person living at home. And importantly, the carer is invited and involved in the entire process. Both are involved in the assessment so that together with the older person and carer, the nurse practitioner drafts a care plan, mainly driven by the older person's preferences. Based on this assessment, the nurse practitioner consults community professionals and already at this stage contacts and arranges carer support. Multidisciplinary team meetings are then arranged as well with all professionals involved, and at these meetings both older people and carers are invited and participate. So I think this is quite a nice example of what I call a triadic collaboration. Finally then, I'd like to turn to the role of healthcare professionals, because as we've heard a lot about in this conference, the values they hold, in this case about carers and role of family within person-centred care, are absolutely critical. It often involves a new mindset for staff to adopt what I call a more carer-friendly approach, to adopt a carer perspective, to see and reach out to carers, to involve them on their terms within the decision-making, to value their expertise, but also to recognise carers' own needs for support. So my final example then consists of an education programme directed at the healthcare workforce in Canada to equip them with skills to help integrate carers within the delivery of person-centred care at their various work settings. It's a foundational education co-designed with over 100 key stakeholders, including carers themselves, comprises 6 modules following domains in a competency framework. It's a flexible delivery, so in person or online, takes about an hour to complete and consists of 6 videos combined with more interactive, reflexive exercises. So I think then, and that's a little bit about the design for you. If I sum up then, give a commentary on the current state of the art in this area, I think we can see that many studies remain small scale. We've already heard that this morning, perhaps with those notable exceptions of the Singapore and the Netherlands example. Some are with solely qualitative evaluation designs, and relatively few employ longitudinal designs, as we heard in some of the literature reviews yesterday. But I think I would like to say that's sort of the glass being half empty in a way. The glass being half full on a positive note, I'd say that increasingly researchers are employing much more sensitive outcome measures that have a closer fit to the aims of the actual intervention. So for example, carer preparedness, predictability, self-mastery for carer education programs, and also perhaps for dyadic interventions involving the person with long-term care needs and the carer. Also exploring outcomes such as satisfaction, rewards of caring, enrichment, as opposed to perhaps the standard or sole use of carer burden measures, which in the case of a time-limited education programme isn't likely to yield any impact. Overall, though, I'd argue, as our previous keynote speakers have highlighted, there still remains a significant gap between carer-friendly policy and research and its implementation within everyday person-centred care practices. This is something we're trying to, apologies for the very busy slide here, This is something we're trying to actively address in our newly started EU Horizon Europe Research and Innovation project, which I have the privilege of heading up, called WellCare. We're directly building on the EU care strategy. Our target groups are both long-term care workers and informal carers. We're interested in the care partnerships, so the mutual recognition and valuing of caring activities of both, as a way to promote the mental health and well-being of both, and of course increase the quality of care and life for people living with long-standing health and care needs. We're working on multiple levels, so micro, meso and macro, in each of our 5 partner European countries, with our target groups, together with service users and variety of stakeholders, which are as follows: frontline health and social care practitioners, care managers, decision makers, patient and service users organisations, carers organisations, professionals associations, employers organisations, trade unions, HR specialists, policymakers, politicians at the different levels and governments. What we're trying to do is create supportive ecosystems, enabling environments to bring about sustainable change, and this will be beyond the lifetime of our 4-year project. Now you're probably thinking, that sounds great. How is she going to go? How are we, not me, are going to go about doing that? One of the methods we're using is called blended learning networks that we employ extensively at our Swedish Family Care Competence Centre. They are basically heterogeneous communities of practice in each of our 5 partner countries, involving our target groups of informal carers, long-term care workers, service users, together with core stakeholders. We're creating a creative forum for shared learning and understandings, and they're acting as a critical sounding board for us within our project consortium, as we, I'm sure, will endeavour challenges along the way. We're employing design thinking methodology for co-designing what we call solution prototypes, and we're going to then be evaluating them using realist evaluation methods, together with social return on investment methods, and actively using narratives. And I'd also like to highlight for you the core idea within the project consortium itself, because we've got a partnership there. We're twinning a research partner and an advocacy organisation in each of our 5 member states. Our advocacy partners, indeed, Brendan, if you're here, are our pirates. Importantly, these advocacy organisations receive 100% funding, so there's no co-financing. So in that way, it's moving towards them being more equal partners. And we also are working actively EU level via several EU level advocacy organisations. There are EU level pirates. Mental Health Europe, Eurocarers. In the disability field, the European Association for Service Providers for People Living with Disabilities, and the European Ageing Network. They're helping us to translate our ongoing research results into core, action-oriented, understandable recommendations targeted at policymakers. So on then to my concluding remarks. I think that each and every one of us in this room today has a role to play in recognising, supporting, empowering informal carers within our person-centred health and care systems, alongside, of course, the person living with long-term health and care needs. To enable carers to choose freely whether they want to be a carer in the first place, and then secondly, to what extent they would like to be involved in caring. Together, we need to work on the following core steps. First and foremost, define and acknowledge carers. Identify your carers. Assess the needs and preferences of your carers. As much as possible, support multi-sectoral care partnerships for integrated and community-based care services. Facilitate carers' access to information and advice about care, caring, and work-life balance. pay attention to carers' health and prevent negative health outcomes, and step in early before it becomes too late. Particularly for high-intensity carers, give carers a regular quality break from caring. Provide carers with access to training and recognise their skills, and prevent carers' poverty and allow them to maintain an active, professional and educational life. And very importantly, adopt a carer's perspective in all relevant policies. And as you've heard from Anders, that isn't simply within health and social care. It's in education for young carers and young adult carers. It's within our pensions. I was going to say labour and pensions for working carers who are endeavouring to balance paid work with care. And within all this, I would argue, the vital cornerstone is the formal long-term care system. Because we're not able to go it alone. The best form of carer support is a well-functioning long-term care system. And we know that where there are gaps and inconsistencies, that's when carers having to step in and provide significant extra amounts of caring. So I call on all of you to, by concluding here, to say and urge, let's work together to create more carer-friendly societies. Thanks very much for your attention.
Thank. So please, Anders, if you would join us, the scene, Elizabeth.
Thank
Do you
you.
want to sit?
Yeah, we can do, yeah.
And please now see if Sofia and Josephine, any kvar? Yeah, now you need to run, surely. So if you have any questions, we have Sofia and Josephine with the mics. So, and you sure do after this, and lovely talks, well-needed talks, I believe also. And I would like to start with, both of you touched upon it, but the big five that you mentioned, Anders, about the labor market, the school systems, insurance systems, and the social services and healthcare. To start with you, Elizabeth, how do you see those big fives concerning both the big EU project, but also other kind of projects that we've worked with? Is it that we forget about those that are not healthcare and maybe social services when we do our healthcare research?
Yes, I think we do, but I think it is starting to change, and I think particularly in the case, in our case of EU funding, where it is much more actively emphasised and encouraged to include advocacy organisations. I think there it's that broader partnership working and recognition that you need to move outside of healthcare and be where the people are. So in our work with young carers, we obviously recognised that schools were a key player. And so we started to engage with school staff, with the student health, with teachers, youth workers and such like. So I think depending on the specific project, I think those type of funding, and also I think even now in Sweden, you know, with the Forte and VR, this partnership working with external actors, I think encourages us to move beyond our comfort zone and start to engage with broader society.
Anders, how do you work with the big five? I mean, you mentioned it, but now with the new project, the Gothenburg initiatives, how do you connect those five?
We connect them by setting up a structure and group where we have representatives from insurance, from social care, school, healthcare, legislation, and adult life, and so forth, and economy as well. For me, it's simple because holistic view is the word for the family who has a child with a chronic disease. Healthcare is the least place they are. They are not so much in healthcare. They are more in the school, and we have found that as well, that children with a rare diagnosis has the diagnosis also give specific complication in learning. And That they don't know in the school because they traditionally had a view on that. The interesting thing is, I feel, is that if you look on a family who have a healthy child, then the system doesn't object. Then the system has, you have no problem with the system. And the system, I think the system goes back to the days of Taylor, when we said that the system, the society is for the normal, if I might say, people, and the rest, they build institution, and we build a lot of other support things outside the society. Then we decided not to have institution anymore, but we didn't correct the regulation. We didn't correct the system accordingly to the heterogeneous group of people who are living in the society today. I have been fighting and thinking that I would change the system. I'm not sure that the system will be changed or is possible. Then the next step is to change the skills and the tools for the people that need the system. Yeah. We've seen that in the family program, that family who get the knowledge in the right way so that they can adopt it. It's not enough to tell a family has a child with a specific diagnosis, read this and then you understand it all. It doesn't work. But if they meet and get that knowledge together with other families who have the same situation, then you open up in a way. And then you can embrace the knowledge and then you can adapt your life. That together with changing the system. And we can't do that without your help. We can't do that with all the knowledge. I've heard these 2 days. It's fantastic. It's an enormous toolbox, but it doesn't build a house.
No.
So we need constructors who build the house. We need carpenter, electrician, and everyone to make use of all this fantastic knowledge we have. And then I think we can, if we adapt that to where the healthcare system or the healthcare is going. I think if we tell the healthcare today, if we tell you Sahlgrenska University Hospital today, you have to implement that and that and that and they say, forget it. We don't have the manpower, we don't have the time, we don't have the money, we will don't do one extra thing. But if we address them and say, okay, but let's do that to the hospital structure you are going to, then I think they will listen up and adopt, and then we can do it together. Because the healthcare situation or the big fast situation we have today, we will not have that in 5 years.
No.
Do we have, it's hard for me to see like this. Oh, yes. Please, Josephine, thank you.
Thank you. I have 2 questions, one for Anders and one for Elizabeth. Should I take them in both together?
Please do.
So, first of all, thank you for bringing the real global here, Anders. I think that was excellent. I truly believe that partnership is the way to go about it. Now, after having worked a long time in the UN, I know that these decisions at the G20 and G7 are extremely important. However, and we know from the knowledge we have here, that the knowledge is there, we know what we need to know. But the problem is that the implementers at the mid-level are squeezed between 2 value systems. One is the economic value system, the other is the soft value system, what we know is right. And we need to get to them in a way different from what we have. And I would like to hear your views on how we can actually create incentives for them to deliver on both, and not only on the economic value. My question to you, Elizabeth, is more on the gender aspect of informal workers. And we see a backlash in the world today on gender equality. And my fear, especially in countries which are low-income countries, is that the increased emphasis on informal workers in the healthcare system will put a burden on also, or diminish the gender equality work. Or how do you see that? Sorry for the long questions.
Okay.
Yeah.
Who wants to start?
I can go.
Anders?
I think it's an excellent question, saying, okay, good to hear what you're saying, but how are we going to make business to this? And the reason is that we started this project first at the Sahlgrenska here at Queen Silvia's Children's Hospital to try to find a way to understand how it looks like, the patient pathway, and also the interaction with the big five, and we put these representatives together in a group. But then we need leverage in this. So when I happen to know Mr. Navid Hanif, and he is a new title. He's a head Sherpa for G20 within the UN system, which means that he has a responsibility to be the communicator with the G20 to Guterres, the head of the UN. So he's absolutely the right person. So I went to him when I was in New York and said, let's do this. Let's have flesh and blood in Gothenburg and UN at the other side and create leverage. And he said, yes. Then he said, you have to frame it. You have to put it in the Agenda 2030. And the one who works with that is WHO in Geneva. So he put me together with them. And I happen to know Hans Kluge, who is the head of WHO Europe very well. So we are friends, and I talked to him. So they are on board in this. So I think we have created an optimal possibility to push the flesh and blood from Queen Silvia into the system and to influence the work they do with the G7 and G20, which eventually will come back. Because all countries in the world, all Ministers of Health are looking for the same way out. Because the problem is the same in every country. So that's, I still believe that this will be provide deliverables in 2026. And I hope GPC will be into this, because the knowledge you have is extraordinary. Was it good enough? Thank you. We are two.
Yeah.
Elizabeth?
Yes, thank you very much for your important question there about the gender and the issues of women providing predominantly the bulk of the care. I think in this area, in terms of work-life balance and care balance, that it's important, that we're working both at the top down and the bottom up. And I think there are different examples, but just quickly, I think in Germany, the top down approach, where the German Federal Ministry of Families has set up since about 2016 an independent advisory committee focusing on how best to reconcile work with informal care, where there are 21 members, and a number of those are from the German carers organisation, Verpflegen, together with a key researcher, Professor Andreas Hoff, in the field. And their function is to monitor the policy implementation of policy reforms on the reconciliation of work and care, and report directly to the ministry. And I think that's very powerful, where the carers organisations themselves are involved. But also, I think there are other approaches from the grassroots up, like, say, in Italy, in the Emilia-Romagna region, where they got legal recognition for carers, where the predominant number of carers are actually women. And in this developing a local carers association, which then started lobbying their city and their local council. They then continued and developed a regional carers association that then led to legal recognition of carers. And part of that work involved providing support services for carers to enable working carers, many of whom were women, to be able to better balance their work and care, and also initiatives to be able to recognise the skills of informal carers, and that they could then be translated into possible entry points for them to enter into the labour market, supported by community organisations that could provide a number of hours of caring, so they could be in the workplace. So I think that's a couple of examples that I'd like to share with you.
Thank you. I need to get some goodie bags for you.
The awards. I've given him hints all day, but he doesn't pick it up.
I would really like to thank you both for having these great presentations and being here also. So a big applause.
Thank you.
Thank you.
Thank you.
Thanks very much. Thank you.
And you said also, Elizabeth, about return of investment in
Yes.
your project, and I think that in order to get a return of investment, you need to invest. And I
That's
think
right.
that's why this conference is so important, in order to understand that what kind of return of the investment do we get here. And I think one return of investment that I at least have gotten from all of you is all the knowledge and the discussions that we had during these days. So in that sense, that's one way of seeing it. And with that said, I think that we should start to wrap things up. And now we go into the award session. So no awards still, yeah. And the recognitions, of course. And Joachim, you're here, perfect. And hi.
Yes. Great. Thank you so much for the speakers, for both of you. Wonderful. So first, we'd like to ask if Elvis Mafiden can come up here. Are you here, Elvis? No. We missed to deliver the bag, the goodie bag, as you said, to him the other day. So, and then I also like to mention first some recognitions about artwork contributions that has, I believe, contributed significantly to the atmosphere. And first, of course, the artwork by Anders Westged, the judging chair, that I believe no one has missed to see, which is very powerful indeed. And just want to mention that the first day on Monday morning, there were some staff passed by, staff at the venue here passed by, and they were about heading very much forward, but they stopped. Oh my! Needing a wheelchair, is that really almost being dead? So I think there are quite a few people who have mentioned that. And then we have Ruhina Rana. Are you here? Yeah, please stand up. And Ruhina brought from Western Canada, big luggage of photos from looking about the impact of the pandemic from health professionals' lenses. Thank you so much. And I know we have Pamela Lindgren and Ida Björkman here. Pamela is over there, and Ida is somewhere here at the front, who brought the cartoons about myths about person-centered care. Did I forget anything now? No.
I don't think so.
Yeah.
Should we proceed?
Yeah, we do.
And these many of you were in our pre-workshops that we had on both Monday and then Tuesday. And we just want to give you some examples of the knowledge that we have gained and from the different workshops. And this is one of the workshops that we had about co-design regarding public involvement in health research and healthcare governance. And they had very good discussions about why we should do it, with whom we should do it, and how we should do it. And during this session, they collected a lot of information about it. And the cool thing is that they, Jana, who led the workshop, they will follow up and also, of course, publish their learning, because this is also important. And if we don't publish and utilize the knowledge that we have, others will not gain from it.
Yeah, and there were another pre-conference workshop on designing person-centered care that was taking place in the Museum of Design in City Center, a few blocks away from here. And it started with presentations of research of designing for incarceration of care by Franz James, Hallevik, and Göran Lindahl. And after that, the participants got to experience an interactive lab facilitated by lecturers and students from Valand University of Design and Art, Academy of Art and Design. And that was also a very exciting and good experience according to the report we got. And then there were additional pre-conference workshops and about person-centered practice development and realist evaluations and about not leadership, culture change in healthcare practices and organizations.
And one of the workshops we had, most of them were here at the venue, of course, but one of them we had at Röhsska Museum.
That's the one we see here.
Yeah, perfect.
Yeah. And then we have, here is from lunch networking with the ICUP community, led by Brenda McCormack, and that was also empowering. And I think I heard comments on that. That sounds interesting. Something to join and find out more about.
Oh, what's that?
Yeah.
Does anyone remember?
I think that not the photo in itself, but you know, it was quite nice and a very kind of energetic dinner with disco afterwards, as we heard from the first keynote speakers this morning. But I think it's also kind of a symbol, because that was truly a co-creation, really embodied, and also involving the spirit. And I think that's what we've done together all days, because the outcome of this conference is about the contributions and co-creations that everyone has contributed with. And if there are anything on the cons and that should have been better, that's about the prerequisites and how we organized it. So that should come back and feed back to us. But the feedback about the benefits and the energy and the networks we've done, that's to everyone. So thanks a lot.
And sadly, this is a picture, and would we have a movie, we have seen a lot of very nice dance moves by many of you. And I heard from Vitalis that they really would like to see them again. And we will come back to it.
But I think also there's another thing about that picture, and it looks like everyone is just staring to a few people on a stage. But that wasn't what happened. There was actually a lot of energy among everyone.
Yes.
Yeah. So, and then we want to acknowledge a few people have been organized it, and I believe you have realized that we too have been part of that team.
So we would like to acknowledge ourselves. No.
So take next play.
No.
Next one.
But this has been the first global conference. There's been a lot of work put in from us and a trial and error, and the team that really did it were them. And I think that, could you just stand up, please, all of you? Anneli, Ida, Hilda, Elin, Hanna, Pamela. Is Pamela here? Nope.
And Pamela is over
and
here.
And Eric. And last but not least, Emma. There. Perfect. I think that you all will sleep good tonight. Not the least after the dancing.
Ja, just det.
Här lägger vi ett foto därifrån. Yeah, we need to. We're a little bit tired, so it's the Swedish way of saying
we
that we'll do it on
next
Monday.
week too.
Yeah, no, we had a lot of volunteers that we of course want to acknowledge also.
Yeah.
So we put in the vote on Monday. That's good.
Yeah.
Thank you
very
so much for all the
important.
works from the volunteers.
Yeah.
Yeah, sorry.
Next one.
Next part. And we also, of course, we have our conference. We call them patient partners, And both Håkan Hedman, I don't think that Håkan is here today, but also Margareta Haag, which is the chair of the Network Against Cancer.
Where are you? Are you here?
And I didn't mention, but Håkan is the chair of the Swedish Kidney Association. And Jana, and I know that Jana is on a seminar and will return from it, which is a co-researcher at GCPCC, did a tremendous job in working with us in this conference.
And, you know, there were, I always forget the number of abstracts. Was it 340? 42? 342 abstracts submitted, and of course we couldn't have managed that to select the good one based on quality assessments without expert reviewers. So that's, and these are included more readable in the abstract book. And we, very important. And we had an abstract book committee.
And the abstract book you can find on our webpage, and also in the app, isn't it correct? The link is in the app also.
And it's also available through the University of Gothenburg library. So it is kind of a publication with ISBN number and so forth. So it could, and at the end of the abstract book, we actually gave a suggestion for how you can put the reference out of your abstracts to put in the CV or for communication purposes.
Perfect. And now, Anders, we'll come to the awards.
Yeah.
So we had some awards, and we start with the awards for which we called for that you could vote for during the sessions.
Yeah.
Exactly. And we start with the first one. Oh, there it is. Perfect. And I just need to, Joachim, can you just read it? I will take the back.
Yeah.
Here.
So the first poster award is for the best layout. And that's a poster from by Lina Ehrenbrandt and colleagues about patients' expectations and experiences of emergency care, video meetings with geographically dispersed staff in primary care, a qualitative interview study in rural Sweden. Come up here, please. Lina.
Yeah, it's a tricky scene, I know. Yeah.
Yeah.
Here we have a diploma and also a goodie bag. Nice work.
Yeah, thanks, congrats.
Perfect. And the next award was for Best Practice-Based Inquiry. And that goes to Joachim?
To Jasmine Appel-Mischlinger and colleagues. A person-centered framework.
Hi.
Oops. A person-centered framework for undergraduate nursing education to foster the development of person-centered practitioners in German-speaking languages. Congrats.
And then we had also post award for novelty, and that goes to
Niklas Olausson and his team.
Thank you.
And that's our boundary situations, a window of opportunity for person-centered care for patients with lung cancer undergoing immunotherapy. Congrats.
It's a little bit like the Eurovision Song Contest. But
Yeah.
here
So
the
we have
voters also win.
two awards to announce.
Yes.
And they have been assessed by a scientific poster award committee. And they
And they worked really hard.
they were scared when they realized the task they got, and finally when they had made the decision, they seems to be quite happy. Yeah. And the first is for scientific quality among PhD students as first authors for posters?
Oh, such a silence in the room.
Så, Kajsa Södergren.
No?
Yeah. Person-centeredness in the context of digital support for stroke rehab. Congrats. And Axel said, it's possible for you to give a comment, if you'd like to.
Well, I'm surprised and happy. I think this is also this subject is very important and close to my heart, combining e-health and person-centeredness. So not forgetting the person in the e-health arena. So thank you.
Thanks.
And then we had an award for the scientific quality of it, and that goes to, we need to have that drum thing.
Yeah. Claudia Silvia.
Var den sista va?
So that's about cultural adaptation and validation of a Portuguese version of a person-centered training program, the mutual meetings. And there's a special motivation for that you...
Oh,
Yeah.
we need to read it out, sorry.
So the overall impression is unscattered and easy to grasp. Different components are well balanced and organized to present a logical flow. The outcomes was well articulated, pointing to the scale of person-centered care in Portuguese healthcare context. The poster included the conference logo demonstrating that the poster was outlined for this conference. Oh dear. And the committee loved posters with QR codes. And there's still one thing to announce, that you are not only the first author of the best scientific quality, you're also PhD students.
Yes, I am. Thank you so much, very much. It's really an honor.
Oh, sorry. That one? And with
Thanks.
Thank you so much. Thank you.
Congrats. Congrats to Claudia and her Portuguese team. Yeah, so
more
what
awards.
happens now with the GCPCC?
See, yes. So, like you see, we are
Seems to be moving.
moving, yes, we are moving, but we are not moving far. No, so we really, I have, and I think it feels that many of us have enjoyed the first global conference, Person-Centered Care, which we think we should do again. Do you agree?
Oh.
So that's why we hope to see all of you and bring your friends to the second GCPCC in Gothenburg. And more info on that will come a little bit later, so stay tuned on the webpage that will be open. And also on our webpage, we will also upload all other stuff. For example, the pictures of that we should do on Monday. But what I'm trying to say is the homepage will be live and will stick around for the next conference also. So there we have a good way to keep in touch and stay informed about what's happening. You okay?
Yes, I think then we want to wish you safe travels home, and that you will have a balance in the way you will care for the close ones in your families, communities, and how they will support and care for you.
Perfect. So with that said, thank you so much and have safe travels. Bye.
Thank you.